Okay, so shall we start?
Yes.
Okay, so hello everyone, and it is my pleasure to welcome you all on this webinar on behalf of Movement Maestro Academy. As we know, we are stuck in the middle of a pandemic, so keeping in view all the safety measures, we decided to celebrate it digitally. So, before introducing you to our speakers, I would like to say something on for this day. As we know, in 1996, the World Physiotherapy Day was declared to be on 8th September. This is the day of establishment of World Physiotherapy in the year 1951. So this day marks the worldwide physiotherapy community's unity and solidarity. This day is dedicated to all the physiotherapists across the world, which aims to recognize their commitment to keep everyone fighting fit. It is an opportunity for us to raise awareness about our crucial commitment and to appreciate the work we all do to keep our society safe, mobile, and healthy. So, because of this pandemic, also, the theme of this year's physiotherapy day is on rehabilitation and COVID 19. So, I guess everyone here is a physiotherapy professional or student. So, without wasting a single minute, as we have so much of speakers today, let me introduce you all to our first speaker. So, he is Dr. Himanshu Mathur. He is the Assistant Professor, Department of Physiotherapy from Jaipur National University. He will be speaking on recuperating lumbopelvic dysfunction. So, we welcome you, sir. The
Hello.
screen is yours.
Good evening.
Good evening, sir.
I hope I'm audible
Yes,
for the
sir.
few.
Yes, sir, you are audible.
Just a second. I'll not be. I'll just be sharing my screen from this.
Okay, sir.
I'll be audible from another login ID of mine.
Okay, okay. No, sir. You are not audible. No, sir.
Hello. Am I audible to you? Hello.
Yes, sir.
Hello.
Now you are audible.
Fine. All right. So I'll be sharing my screen from here. Can you see my screen?
Yes, sir. It is visible.
All right. So, first of all, before I start anything, let me convey very happy World Physiotherapy Day to all the physiotherapists here, on which you are listening to me right now, and all those who will be listening to me afterwards, if this is getting live streamed somewhere. So, I'm Dr. Himanshu Mathur, as Ram said, and I'm working as an assistant professor in the Department of Physiotherapy, Jaipur National University, and I'm also working as a chief.
Hello, sir.
Yeah.
Hello, sir. Your voice is not clear. It's breaking in between.
Okay. Wait, then I'll just. Hello, is it okay now?
Yes, sir. Now it is okay.
Just okay. So I'm working as a chief physiotherapist for my physio. I'm also working as a chief physiotherapist and director for Jaipur Rehab. So today I'll be talking about recuperating lumbopelvic dysfunctions. So what eventually I wanted to talk about and what eventually compelled me to take this topic was everybody who are clinicians. I must say that you must be having more than 50% cases in your OPDs which are filled with back pain. And there have been studies that suggest to you that 85% of the global population will have low back pain once in their life. So whenever I say that 85% of the global population has this pain once in their life, So that becomes a very big figure for us, right? So if I consider India to be a country of say 130 crore people, and I say almost 85% people will be having low back pains once in their life, so that becomes a population of say 110 crore people. If I start treating people of low back pain today, and I continue treating all throughout my life till I get 65 years old, and if I see every different patient every hour, every day, in that case also I cannot complete 110 crore people in my lifetime. So I always plead to everybody, I always request to everybody, if you know something good, then please share. It might not be complete, it might not be that comprehensive, but if you know something good that can help the mankind, I would suggest you to share your thoughts. Okay, make your copies rather. Okay, if I alone try to see 110 crore people, I might not be able to see. But if people like me, if I teach my own techniques to three people, they teach it to again three people, or more than that. So in this way, we can treat 110 crore people, right? Moving a little ahead, let me start with the talk I have been bestowed with. So this is a figure written. It's called 10.283 crore. Can you guess what this figure is? I hope this would have been my bank balance, but this 10.283 crore is not my bank balance. So what this figure is? So this figure is the global burden of musculoskeletal disorders in the year 2016. It was done by, this prevalence study was done by WHO, suggested us. So whenever I say 10.283 crore people just suffering from musculoskeletal disorders, then my friend, this number becomes very big. Okay, 10.283 crore patients just suffering from musculoskeletal disorders, right? So this is a big number when I just talk about musculoskeletal disorders, right? Moving ahead, let us see that how these musculoskeletal disorders, or 10 crore people, are distributed amongst various disorders of the musculoskeletal thing. Somebody's on chat, I suppose. Disturbance in backside, but there is nobody around me. What should I do? Wait, I'll just.
So I will ask everyone to please switch off their mic. Please check on your mic.
Okay, is it better?
Yes, sir. Now.
Shall I continue?
Yes, sir.
There's somebody else in the chat. Okay, yes, great. So let us see that how these 10.23 crore people have been distinguished in various disorders. Okay, so 6% of people were suffering from rheumatoid arthritis, 16% from osteoarthritis, 1% gout, and the major cohort came with back, neck, and shoulder pain, right? That was 46% of the total population was suffering from back, neck, and shoulder pain, right? And the rest, 31%, was suffering from soft. So this is the major pie. This is the major surface area of the pie chart we'll be looking at, right? That is why I chose this topic, because almost nearly 50% of the population, half of the population nearly, was suffering from back, neck, and shoulder pain. So this becomes a very potential topic to be discussed with us, right? As I told you that within chronic pain population, low back pain is one of the most prevalent musculoskeletal disorders, affecting 70 to 85% of population at some point of time in their life. Okay, so always remember, even if you practice low back pain well and you open a clinic only for low back pain, trust me, your super specialty clinic can work wonderfully throughout your life. You don't have to look for any other disorder. Okay, and amongst that, 30% of those low back pains suffer from SI joint pain or SI joint dysfunction, right? It is always a misdiagnosed thing or a misnomer sort of thing, that we try to diagnose a low back pain, but we eventually leave, or we don't concentrate more onto the SI joint, or the thing what I'll be taking today, that is the pelvic dysfunction. Okay, how we always talk about sacroiliac dysfunctions, we hardly talk about iliosacral dysfunction. So today we'll be talking about the iliosacral dysfunctions as well. Okay. Now, This area is a very important area because this serves as a key link between upper body and lower body. So sacroiliac joint or iliosacral segment serves to be a link for weight transference from the upper body to the lower body. Right? That is why it becomes of a greater importance. Okay. Moving forward, that how do we see the lumbopelvic complex? There are various views that different people can see, even clinicians, even academicians, people who teach you, people who treat you. Okay, they can see it in different ways. So what could be the different ways that can we see that? The first one is the lumbar segments, 5 lumbar segments that we can treat, see and assist, right? Then comes the lumbosacral segment, that is the L5S1 segment. That these all are the segments that our textbook talk about very commonly. The third one is the sacroiliac segment. Sacroiliac segment, kinematics, the force distribution, the disorders or the treatment, everybody talks about that. But the last one becomes your iliosacral segment. Iliosacral segment is one thing that hardly people look upon to, right? That is why I always wanted people to have their concentration on the iliosacral segments as well. Okay, because whenever we talk about the lumbar segments, we have just common 3 degrees of freedom, flexion, extension, side bending, side rotations as well. Okay, lumbosacral segment also there is 3 degrees of movement. Sacroiliac segment we usually talk about nutation, counter nutation, right? And but along with that, while gait also during walking also we have several torsions available in the sacrum. Talking about the iliosacral segment, I'll be telling you what sort of the movements are available at the iliosacral segment, and these are only the fixed deformities or fixed dysfunctions of this particular segment. All right. Now, first, moving on to the biomechanics. So, whenever I say about biomechanics, I won't only tell you the biomechanics of this particular region, I'll be telling you the biomechanics of the whole or the alignment of faces of the whole of the whole spine. Okay, starting from the C0, C1. Whenever I talk about the C0, C1, C0 is the occipital condyle. Okay, the articulating surface for C0 is the convex shape occipital condyle, which rest on a relatively concave but transverse. They are located in transverse plane. These are the superior faces of your this what you can say C1, that is atlas. Okay. Followed by C1, C2. Whenever I talk about C1, C2, what do we have is the facet is aligned in say almost 15 degrees of transverse plane. We have alignment of 15-degree transverse plane here. Okay, almost 15 to 20 degrees there. Coming on to the rest of the cervical spine, we have 40 degrees of inclination from the sagittal plane. Okay, so rest of the cervical spine, we have 40 degrees inclination from the sagittal plane. Okay, this is that plane. You can say this is the frontal plane. Okay, so 45 degrees into the sagittal plane from the frontal plane. Okay, coming on to the thoracic spine, this angle reduces to 15 degrees. Okay, again 15 degrees from the frontal plane into the sagittal plane. Talking about the lumbar spine has almost 25 degrees from the sagittal plane. So it becomes like this. Okay, if this is the sagittal plane, it becomes 25 degrees inclined or tilted from the sagittal plane. Okay, and whenever we talk about L5S1 junction, it is more over into the this vertical plane. All right. So that again becomes your 25 degrees. So I repeat it again. Whenever we talk about early cervical spine, it is 45 degrees from the frontal plane into the sagittal plane. Thoracic spine, it reduces to 15 degrees. Okay. Cervical, it was 45. In thoracic, it reduces to 15 degrees from the frontal plane. Okay. And whenever we talk about the lumbar spine, it is 25 degrees from the sagittal plane. So you need to know about this, okay, the alignment of faces. And whenever we talk about the basic biomechanics or basic arthrokinematics of the lumbar spine, we always say one thing. Suppose whenever I'm talking about the lumbar spine, the moving facets are the inferior facets of the superior vertebra. Suppose this is the superior vertebra and this is the inferior vertebra. These facets are the inferior facets of the superior vertebra, right? I'll be writing it. Inferior facet of the superior vertebra, and these are the superior facet of the inferior vertebra. Okay, so the moving surface will always be the inferior facet of the superior vertebra. So now what happens is, I told you that they are located in 25 degrees from sagittal plane. So whenever I do sagittal plane motion, the faces, bilateral faces, right? Both the faces goes anteriorly and superiorly. Okay, whenever I move forward into flexion in sagittal plane, it goes anterior and superior. Whenever I come back into extension, it goes like posterior and inferior. Okay, so whenever I am talking about the flexion component, it is going superior and anterior. Okay, when I am talking about extension, it is coming inferior plus posterior. All right. So the movement of inferior facet of the superior vertebra will be superior and anterior during flexion and inferior and posterior during extension. All right. Whenever I am going side flexion towards right side, there is more approximation, or inferior and posterior on the ipsilateral side and superior and anterior on the opposite side. Right. So there will be contralateral side, it will be superior and anterior. Okay, ipsilateral side, it will be posterior and inferior, right? It will be valid for both the things, right? If I'm going on the left side, it will be posterior inferior on the left side, and on the right side it will go superior and anterior. Okay, and whenever I'm talking about the transverse plane motion, about the rotations, so in the rotation, if I'm doing it on the right side, so ipsilateral side, there will be more approximation. Both the articular surfaces of the facet joint will come close to each other, and there will be de-approximation or distraction on the opposite side, on the contralateral side. Okay, approximation or the articular surfaces will come closer on the ipsilateral side, and they'll get de-approximate, or they'll get distracted on the opposite side. All right, so always remember that. Moving a little ahead, I just want you people to see this small video. This is what has been told in this. So this is how the flexion is taking place. You can see that the inferior facet of the superior vertebra is going superior and anterior, while the superior facet of the inferior vertebra is not moving, right? You can see it posteriorly that the neural foramina also gets opened. I'll be talking a little later about it. All right. Okay, can you tell me that was the audio of that video was visible, was audible? Can anybody please tell me? Was the audio from the video, the music in the video, was audible to you?
No, sir. It was very slow.
Well, it was very good. Okay, then just give me a while. I'll just stop share and reshare it again. Okay, just give
Okay.
me a second. Just give me a second.
Okay.
Because for some few things I want this to be audible to you. Wait. Okay, is my screen visible to everybody?
Yes, sir.
Okay, perfect. Coming on to another aspect of the mechanics or the force distribution at the sacroiliac segment, we need to know two things that helps for the stability. As we know that iliosacral segment or sacroiliac segment that we are talking about, they are very much of importance when we say that they it acts as a key link between the upper body and the lower body, because it helps in the weight transference from upper body to the lower body. All right, so we get to know about two concepts or two terms that comes into action. One is the form closure, the other one is force closure. Now I'll tell you what is form closure and what is force closure. Form closure is I don't know how many of you have seen the structure of the SI joint. Is like it's a stellate sort of bone. Okay, it's a thin sort of bone. Okay, you which is being attached onto or which is being kept onto the on the medial most aspect of the ilium, okay, which has been which is geometrically not meant to be a congruent stabilization or congruent joint making over there. Okay, so it is just being kept over there. Geometrically or articularly, these two bones are not meant to be congruent, so they are not meant to make a stable joint over here. Okay, so we do not have a natural or a articular stability over here. All right, so ideally the shape of sacrum is not that straight. It is a little curved from superior side. Okay, it's something like this going. Okay, so now this curvature, this shape allows some amount of stability or some amount of holding at these medial most points of the ilium. All right, so this articular congruency, which is of very low quality or which is very less stability, is usually known as form closure. Now, if there is no articular congruency or there is no articular stability associated with it, we require some soft tissues which has to, what you can say, reinforce these structures so as to be stable, because we require a lot of stability. What we usually talk about in biomechanics are the joints which are not articularly congruent or geometrically congruent. They are meant for mobility more than stability, right? But we cannot say this here because this joint does not have an articular congruency, but at the same time this joint is not meant for mobility. This joint is meant for stability, because this joint has to be stable if it has to transfer the upper body weight to the lower body, right? Now, what are the structures that helps to maintain this sort of stability? There could be contractile structures as well. There could be non-contractile structures, right? Non-contractile structures are the ligament, capsule, and the other soft tissue structures which are located in the adjoining area. Mostly there are capsule, thickened anterior capsule, and the other ligaments which are located across the SI joint or the sacroiliac and iliosacral complex, helps to increase the static stability or helps to increase the stability of this particular joint. At the same time, there are a lot of muscles also that crosses this particular joint and helps to stabilize. Now, how do we measure or how do we say that a particular muscle is allowing or how does a particular muscle is having a stability action at that particular joint or mobility action? For this, I would like to take you to some basic concepts of biomechanics. I always keep these concepts in my class. Now, so as a muscle, if a muscle has to cause any movement at any joint, the muscle must has certain torque. Okay, torque is the force which is responsible or required to cause an angular motion. So for all the joints which are present, all the synovial joint which has movement has range of motion. The movement has range of motion, and range of motion is an angular motion, right? Now, so as to cause an angular motion, it is a lever, because it's a lever. So all the levers has angular motion, and so as to generate an angular motion, we require a force, and that force is known as torque. Okay, and torque is equals to force into momentum. All right, force we all know is the muscle force. It is generated by the muscle. Now, momentum is the perpendicular distance from the point of attachment of the muscle, that is the site of location of the effort. Okay, application of the effort. From that point, a perpendicular distance to the fulcrum, that is the point of the joint from where the axis is passing. Okay, that is the momentum. Now, if you can directly see here that torque is directly proportional to momentum. If torque is directly proportional to momentum, it means that bigger the momentum, bigger will be the torque. It means bigger the perpendicular distance, more the muscle will be able to generate some amount of torque to cause movement. Okay, because the major action of the muscle is to cause movement. Lesser the momentum, lesser will be the torque. So the muscle will not be able to generate sufficient torque such that it could cause a movement. In that case, those muscles which are located close to the joint, if the muscle is located very close to the joint, very close to the fulcrum, in that case, the momentum of that particular muscle will be less. If the momentum of that particular muscle will be less, the torque generated by that particular muscle will also be less. In that case, that muscle will not be called a mobilizer. Okay, that will be called a stabilizer. Okay, On the other hand, the muscles which are located more superior, more superficially, okay, the muscles which are located more superficially are relatively away from the fulcrum. If those muscles are away from the fulcrum, they have larger momentum. If they have larger momentum, they'll able to generate greater torque. If they'll be able to generate greater torque, it means they'll be able to generate sufficient torque such that so as to cause some movement at that particular joint. Okay, in that case, those muscles will be mobilizers. So the muscles which are located away or superficial in relationship with the joint or in relationship with the fulcrum are the mobilizers, and the deeply placed muscles are the stabilizers. Okay, and those stabilizers functions as your force closure. Okay, they aid to the force closure. I hope that was easier for you people. Now, this is a very commonly clinically classified low back pain, I would say, the pain in the lower back. So how can we usually classify that? And even whenever you see ICIDH model, they also classify it somewhere like this. So what is being said here is low back pain with mobility deficits is what you can have. Low back pain with referred pain or radiating pain is what you can have. Low back pain with movement impairment syndrome is what you can have. Low back pain with cognitive tendencies what you can have. We'll be looking onto a few of them today, but I don't think the scope of this lecture would allow me to go through for all of them. Okay, so we'll try to see a few of them if we are able to. Okay, coming on to the disorders of the lumbopelvic or the iliosacral complex. I would like to take you a few slides back when I said the views that how can you see the lumbopelvic segment, right? We talked about the lumbar segments, we talked about the lumbosacral segments, we talked about the sacroiliac segment. So whenever I say dysfunction or movement or kinematics at the sacroiliac segment, it always tells you that movement of sacrum with respect to the fixed pelvis is the sacroiliac motion. But there are evidences that says that the pelvis could equally to the fixed sacrum or with respect to the non-moving sacrum. Now you'll say that we usually study that in our first years of BPT, and there are other books also that suggest that there are pelvic motions, there is an anterior tilt, there is a posterior tilt, there are pelvic rotations, there are pelvic tiltings. But those books or those evidences tells you that the pelvis moves as a complex. Both the pelvis moves as a unit. That is why in the starting also I'm not calling it as a pelvic complex. I'm telling it as a iliosacral complex. Okay, there is one ilium, one side sacrum. They are making a complex. Okay, it's not both the pelvis which are making the complex. So there have been studies that suggest us that unilateral pelvis can have a movement as well. It is not necessary always to have both the pelvis rotating or both the pelvis moving along with at the same time simultaneously. So there can be different pelvis which moves in different ways, or it could be that one pelvis is fixed or the other one is moving. So that is where the concept of iliosacral motion also comes in, that the sacrum is anyways stationary, but at the same time the contralateral pelvis is also not moving, or if it is moving, it is moving in the other direction. So right now we are talking about only unilateral pelvis. So we are talking about unilateral pelvis motion. Okay, now when I talk about unilateral pelvis motion, it is not like that it is anterior tilt, it is rotation, or it is side tilting like that. It also does have 3 degrees of freedom. So the movement that are suggested in iliosacral complex are that whenever the unilateral pelvis moves superior with respect to the other fixed pelvis, it is called the upslip of the pelvis, unilateral pelvis. I must tell you that, right? Whenever the same pelvis goes down with respect to the other pelvis, this is called downslip of the pelvis. Whenever the unilateral pelvis rotates outward with respect to the other fixed pelvis, it is called outflare of the pelvis. Whenever this pelvis, unilateral pelvis, rotates relatively inwards with respect to the other fixed pelvis, it is called your influx. Whenever the unilateral pelvis goes a little more anterior, rotates anterior more, okay, in an anterior tilt, unilateral anterior tilt, it's called anterior rotation. And whenever that particular unilateral pelvis goes posterior, it is called posterior tilting. Okay, so these are the six motion that has been defined, and whenever the unilateral pelvis gets fixed into this position because of some because of some instability or because of some jerk or relative malposition of the sacrum also. So these particular positions only or these movements only becomes the relative dysfunction of the unilateral pelvis. Okay, so we can treat or we can diagnose upslip, you can diagnose downslip, you can diagnose outflare, you can diagnose inflare, you can diagnose anterior rotation, you can diagnose posterior rotation of the pelvis. All right. Now, other pain producing structures, this is something important and this is something different. I want you people to listen. Before moving ahead in this, I would like to you people to recall one thing. I told you one thing earlier. What it was, when I was telling you the kinematics of the lumbar segment, or the arthrokinematics of the lumbar segment, I told you one thing. Whenever I go for striatal plane motion of flexion, there the facets, the inferior facet of the superiorly lying vertebra goes anterior and superior. Okay, whenever I'm going for flexion, the inferior facet of the superior vertebra is going superior and anterior. And whenever I'm coming back into extension, the inferior facet of the superior vertebra is coming posterior and inferior. Now, what happens is since zygapophyseal joint or the facial joint is again a synovial joint, there is a synovial lining associated with this joint. Okay, and you have, along with the synovial lining, you have some synovial folds also present. Okay, now these synovial folds, there is an anterior synovial fold also, there is a posterior synovial fold also. Okay, let me draw it and then tell it to you. You'll be easily able to understand. Suppose this is one facet, this is the other facet. Okay, this is the inferior facet of the superior vertebra, this is the superior facet of the inferior vertebra. So this is the moving facet. Okay, this goes forward in flexion and it comes back in extension. So whenever I talk about the synovial folds, there is a synovial fold, anterior synovial fold like this, and there is a posterior synovial fold like this. Okay, anterior synovial fold is very poorly innervated. It is not that much that much good innervation, right? On the contrary, the posterior synovial fold has good innervation. Okay, it is richly innervated. Now what happens is, this is somewhere is attached to the posterior capsule of the zygapophyseal joint, and on the contrary, that capsule is further attached to a muscle that is called your multifidus. Okay, this capsule is attached to multifidus. So whenever a person goes into extension of the lumbar spine, whenever this inferior facet of the superior vertebra is coming back in extension, ideally multifidus contracts and they pull the capsule posterior, and along with this capsule being pulled posterior, the posterior synovial fold is also pulled posterior and it comes out of the articular surfaces. Okay, usually it lies between the articular surfaces, but it usually comes out of the articular surface. This is the normal physiology. But in cases, in the patients, those who have any iliosacral dysfunction, any sacroiliac dysfunction, any muscular dysfunction, any muscular imbalances, or they have a reduced endurance of the back extensors, which is the reduced tone of the multifidus muscle. Okay, in that case, it could be that a case where the multifidus is unable to pull this posterior synovial fold posterior. In that case, this richly innervated posterior synovial fold get impinged between the two articular surfaces of the zygapophyseal joint, and this eventually causes pain. And there are a lot of cases in during MRIs also that these situations remain undiagnosed. Okay, now I'll tell you a few, show you a few structures or diagrammatic forms which I was telling you about. Uh, Okay, this is the posterior synovial fold I was talking about. This is the anterior synovial fold I was talking about, right? So this is further attached to the capsule, and the capsule is further attached to the multifidus muscle. Similarly, there is a histological approach and picture that is showing it to you in this also. All right, this is a slide which is showing you this posterior synovial fold is being attached to further to the capsule. All right. So usually what happens is patient complains of extension during the back, and what physios and the other clinicians, what do is they usually diagnose it as lumbar canal stenosis without looking at the MRIs. Okay, so it is always prescribed to see the film of the MRI rather than looking at the report of the MRI, because the report of the MRI is usually misleading. Okay, so I have little time. What happens is, again, always then now I'll be starting with the general examination of the this low back pain. I hope I'm not violating any time guidelines over here. So whenever we say about the examination of the low back or low back pain, always start with SLR. And I must tell you that SLR people, what do people? I've seen students. I'm working in academic institution. I've seen students under me. I've seen students in the clinic also. That what's the basic problem that they do is they ask the patient to lift the leg up in the air with the knee extended. So I must tell everybody who's listening to me, SLR, when we read Mma-Gha also, it's written in the very first 2-3 lines that SLR is not an active procedure. It's not an active procedure. It's a passive procedure. Okay. You make sure that all the other adjoining structures, soft tissue structures, or the muscle that you are targeting, they must not be contracted. Okay. Because if they are contracted, you might get false positive result. In examination, you must know a very important thing, that you are not getting any false positive result. Okay, because the false positive results takes you away from your diagnosis, and eventually they are the biggest threat to the sensitivity of your examination or assessment. Okay, so always try to make sure and read properly that what is the process of a particular test and what is the reliability of a particular test. All right, so that is how it becomes a little easier for you people. All right, you must know the findings of SLR. At if it is painful at 60 degree, what is the finding? It must be your muscular structures that are painful. If it is beyond 70 degree, then facets are being compressed. So the pain the patient is having might be because of the facet. All right, so you must know about it. When the hamstring action takes up to the game, and when the stretch in the sciatic nerve gives you any result, right? So another thing that what we look into action is what can be the structures involved based upon the area. You must know that where the pain actually is. So whenever you say that the patient is having pain in the back or in the lower leg, and I must tell you one important thing, that every pain that comes from starting from the lower back into your leg, it is not a radiating pain. Okay, every pain, you must know how to distinguish between different pains that are coming or different symptoms that the patient is complaining of. Okay, usually in most of the cases that I have seen, that the patient does not have a radiating symptoms. Just a second. Okay, what I was talking about, that you must know to distinguish between various symptoms. You must know that when the patient is complaining you, or when the targeted structure would be a neural structure, when it could be a musculoskeletal structure. If the patient complains you of symptoms that are tingling, that are pricking, that are pins and needles like sensation, or that are numbness, when the patient complains you that, in that case only the patient would be having a neurological symptoms, or you need some neurological examination for that. If the patient says that yes, the pain is coming to my leg, but I don't feel any tingling, pricking, or numbness, or what you can say, pins and needle sensation, right? So in that case, it is quite possible that the targeted structure is not neural. Okay, it could be myofascial, it could be muscular, it could be a hamstring length. Okay, so you must know how to distinguish between symptoms. All right, so if you have distinguished, if you have ruled out the neural symptoms, look for the musculoskeletal symptoms, if the symptom is articular or if it is a soft tissue symptom. Okay, now for that you need to go for active and passive assessment. Try to go for a passive assessment if the range of motion for that particular joint is complete. That is what we call as passive physiological movement testing. If you get the range of motion complete for that, in that case you don't have any articular involvement. Now if it is not articular involvement, it could be a soft tissue involvement. Now, if it is a soft tissue involvement, you must know a diversification, that if it could be a contractile tissue involvement, if it could be a non-contractile tissue involvement, right? Then try to go for a resisted isometric contraction of that particular muscle. So whenever you go for a resisted isometric contraction of that particular muscle, there is a concept of autogenic inhibition. Okay, so just after the contraction, isometric contraction of that particular muscle goes off, the muscle comes to a relaxed position even better than its original length. Okay, so if the symptoms get better once you complete the rested isometric contraction, in that case it could be a contractile tissue. And if there is no change happening, in that case you might have a non-contractile tissue involvement also. But what we do is, for this, we go for a stretch of that particular soft tissue. The stretch could be there. A stretch could produce pain in the cases of this contractile tissue also, or non-contractile tissue also. Okay, so it could be a misleading answer for you people also. All right, so I have told you about all these things which I have written over here. Now, looking on to the combined motion testing. In combined motion testing, I usually take two movements through which we can do a motion testing. We can ask a patient to stand straight in the normal way that he stands. Okay, you don't have to let the patient adapt any other postural thing, or you don't have to ask him to adapt any position for standing. Let him stand in the way he stands, he or she stands. So what you have to do is, you have to incorporate slightly plane motion along with the frontal plane motion. Okay, so along with flexion, you ask the patient to go for side bending onto the right side, side bending onto the left side. Okay, again with the extension also, you ask the patient to go for side bending on the right side and side bending onto the left side. So by this combined motion testing, we get 4 quadrants. Okay, 4 quadrant is flexion with right side bending. It means it is a right anterior quadrant. Flexion is I'm moving the body anteriorly and I'm going right side. So that is right anterior quadrant. Similarly, flexion with left side bending becomes your left anterior quadrant. And extension becomes your posterior compartment or posterior component. And in along with extension, if I'm going to right side bending, that becomes your right posterior quadrant. And that extension with left side bending becomes your left posterior quadrant. Okay, so let us see that what results or what outcome we can get in all those quadrants. Okay, before that, you can see this small video of combined motion testing. It's just a small animated thing what you can see here. Okay, did you get the background music of that video? Okay, you can just thumbs up if you got the background music of the video. There's somebody on the chat. Yes, great. Okay. Okay. Now, talking about the 4 quadrants that I just demonstrated it to you. First one that I'll be talking about, flexion with left side bending. It means it is our left anterior quadrant. Okay. Now, what left anterior quadrants physiologically leads up to? First thing is the articular facets, the articular surface of the facet moves away. I am going for flexion. So both the articular surfaces, the inferior facet of the superior vertebra will be going superior and anterior. So both the articular surfaces are distracted from each other. So in this case, I can easily rule out that there is no degenerative condition in the facet. It is not the facet joint arthropathy. Okay, I can easily rule out because I am doing a flexion thing. Now, left approximation and right side distraction. Whenever I am doing left side bending, the articular surfaces are coming towards each other. Although it is not a perfect approximation, but they are coming towards each other, and there is a de-approximation or distraction on the right side. And at the same time, the neural foramina on the right side also opens up. Okay, although whenever I'm going for flexion, both side neural foramina opens up, but whenever I'm going for left side bending, the neural foramina of the right side opens up, along with the disc that is compressed anteriorly. Okay, there could be discal symptoms also. Okay, let me tell you that most of the MRIs that tells us, or which are being shown to us in our clinical practice, they 60 to 70% MRI shows us prolapsed intervertebral disc. Okay, so whenever a patient comes to you with prolapsed intervertebral disc and says that I just had a PIVD or a slip disc yesterday, or I just had a PIVD 3 days back, or 7 days back, or 10 days back, in that case, in the acute stages of PIVD, you will go for extension exercise and try to prevent further damage to the that is annular fibers. Okay, and you try to prevent the further translation of or further prolapse of that particular disc. But if a patient who comes to you and says that I had a slip disc 6 months or 8 months back and I still have pain, then you must go for a comprehensive examination. The best treatment or the best assessment for acute disc pain is the Valsalva test. Okay, you just ask the patient to cough, you just ask the patient to laugh, or you just ask the patient to perform any activity that increases the intra-abdominal pressure. If on increasing intra-abdominal pressure, the patient says that the pain gets spreaded in a particular belt-like region, or it goes down also in that particular area whenever I increase the intra-abdominal pressure, it is a very valid test which suggests you that it could be a discal symptom. Okay, if the patient usually doesn't tell you, and what actually happens is, if the patient comes to you after say 8 months or 1 year or 1.5 years after a disc prolapse, the patient is not coming in for disc. He is coming for the adjoining symptoms which he has developed because of the activities pertaining to prolapse intervertebral disc. It could be definitely, it could be muscle stiffness, it could be another myofascial symptoms, it could be your facet arthropathies or facet stiffness, hypermobility of the facet, it could be that, right? So there could be ample of other ailments that the patient is carrying despite of your just prolapse intervertebral disc. But your MRI readings or the MRI reports only shows you that the patient is having prolapse intervertebral disc, and you start treating the patient in prolapse intervertebral disc. A patient with a history of say 8 months or 1 year history of prolapse intervertebral disc must be coming you with a very hypertonic or tight extensors of back, because of, you can say that it could be a prophylactic tightness in the erectrospinal. And what you do for that is you are suggesting the patient some extension regime exercises. So those extension regime exercises are not good for that particular patient. Those extension regime exercises are eventually hampering the patient. Okay, you are actually tightening those muscles which are already tight. Okay, so you must go through and you must do a comprehensive assessment before you end up with a result and you end up with a proposed regime for that particular patient. Okay, so in the same flexion and left side bending, you can also have right side capsule stretch, capsule of the facet joint. Okay, and the muscle stretch could also be there. Now, if it is a capsular stretch, it will be throughout the range of motion. But if it is a muscle stretch only appears at the end range of motion. So if the patient says I don't have pain any sort of here, so but there is a pain whenever I reach this position or whenever I cross this particular position, then it could be a muscular tightness. And if the patient says I have pain, which is being increasing throughout the range of motion, then it could be tightness or adhesion in your facet joint also. All right. Similar things, what you can see here. Just a second. See, here is flexion with a right side bending also. So what you can see, what outcomes can you see here is articular surface facets moves away. That is a right side approximation this time and distraction on the left side. Disc compresses anteriorly and neural foramina opens ideally on both sides, but it is more on the left side this time. Okay. Now left side capsule stretch is there and muscle stretch can also be there. Then comes your posterior quadrant, that is posterior left quadrant. Posterior left quadrant articular surface approximation is there. Now, if the patient complains you that the pain increases as I am going into extension, then it could be the weakness of multifidus muscle, which could not pull your this posterior synovial fold posteriorly. Okay, with the help of the capsule. All right. So this could be a potential reason. Although you must rule out the spinal canal, lumbar canal stenosis also, because it can be again a possible reason. But trust me, if it is a spinal canal stenosis which is producing pain on extension, then you must have a claudication also, intermittent claudication also associated with that. So if it is not there, you might have this particular situation. So whenever I talk about the extension and left side bending, the articular surface of the facet approximate, the disc is compressed on the posterior side now. And if it is a left side bending associated with it, then more compression is there on the left side, left posterior side, right? Neural foramina opens on the right side and closes on the left side, right? Whenever I go into left side bending with the extension also, the neural foramina of the right side opens up and the right side anterior, right anterior the capsule or the annular fibers on the right side, they get stretched out. All right. Similar things or the opposite things happens when I go for extension and right side bending. The articular surface of the facet gets approximated. The disc is compressed on the right posterior side. The neural foramina opens on the left side and closes on the right side. And right anterior structures of that particular segment opens up, or they get stretched out. All right. So this is what I wanted to tell you. This important information I wanted to share it with you. And after that, when we go into more assessment, you must know about. Okay, there's somebody in the chat. Okay. Just a few more slides, then I'll be wrapping up. We must know, must have a knowledge of the concept of SINS. SINS stands for severity of symptoms, irritability, and nature. I'll just give you a very small brief guideline about it. If SIN is high, then always select a quadrant out of the previous slide that we were talking about. So always select a quadrant in which this SIN gets lower. If the patient comes with a higher intensity of pain, irritability, and the nature is also, say, a tingling sort of pain or a capsular pain the patient is telling you, so always go select a quadrant and then treat the patient which has low SIN. And if the patient comes with a low SIN, then you can start it with a neutral and then come to the offending quadrant also. All right. And in that also, if the patient comes with a high SIN, in that case also, first you can go with that quadrant in which the SIN is low, then later on you can come on to the neutral, and then you can come on to the offending quadrant. All right. PAIVM, I'll be telling you with the mobilization, the technique is exactly same. It's just like that. We have to see that if the particular segment is hypermobile, normal, or a hypermobile sort of situation. All right. What we have to do is we just keep our this ulnar border of our hand onto the segment on which we have to treat the patient. My chest and my body is just above the segment to be treated. I reinforce my hand with the other hand, and with the extended elbows and shoulders, straight shoulders, I just rock my trunk forward and backward, such that I'm usually able to know that if there is some amount of mobility between the segment or not. So these are the glides that we give usually. That could be central PA if I'm giving it directly onto the spinous process. It can be unilateral PA on the right, on the left side. That could be related to your facet joint. It could be transverse glide onto the left or the right side. That could be on the transverse process for the rotational segment mode. Okay. Strategies for spinal mobilization, the same thing what we're talking about. I want you people to see a video of it.
Now, so as to mobilize or perform Maitland mobilization, what you need to do is you just have to keep your hand and the ulnar border of your hand on the, or any hand you can use, whatever is your dominant hand or non-dominant hand, whatever. So you just have to keep your ulnar border of your hand onto the spinous process like this, and just reinforce it with the other hand. Keeping your elbows straight and your shoulders straight, you just have to rock your trunk forward and backward. You just have to rock it forward and backward. Make sure that your body comes just above the joint you are mobilizing. So this glide is known as central PA. That is, you are giving a posterior-anterior glide to a particular intervertebral segment. Now, moving on to the other glides, the next glide that comes to us is the unilateral PA. Unilateral PA is actually the mobilization of facet, and we know the palpation of facet individually. Now, so as to palpate or to mobilize the facet joint, either you can keep your ulnar border of your hand onto that area, the same palpation, or you can just keep the heel of your hand onto that particular area, keeping your elbows and shoulders straight. Just keep your trunk over the segment to be mobilized, and just rock your trunk forward and backward, to and fro. This will give you a mobilization of the particular facet joint. This can be performed on the right side as well as on the left side. So that becomes your right unilateral PA and left unilateral PA. Now, so as to perform a transverse glide, it could be performed in different ways. it can be given onto the spinous process, so you can have just a palpation and just a grip like this. You can palpate on either side of this and just mobilize it on either side like this also. Now if you have to perform a transverse glide on either side for the transverse process so as to facilitate the rotational movement, you can just perform this glide. Just keep your ulnar border of the hand on the transverse process, which lies again a little lateral to the facet joint that we have palpated. Just keep it like this here and the other one this here, and you can palpate it on one side. Stabilizing the other side, you can palpate it on the other side.
So this is what I wanted to tell you people. I'll just take this last thing and I won't take the root one because I think I'm running a little short of time. So when we talk about the pelvic mobilizations, so there is an osteopathic school of medicine that says that it is not the pelvis that moves in only the three planes, right? What I told you, anterior rotation, posterior rotation, outward, inferior, or upstream, downstream. It acts or it works or it moves onto an oblique axis into a rotation which is combination of all these stuff that I've told you. So there could be two movements that are suggested by that osteopathic manipulation school. So that is, one is antero-superior and one is the posterior-inferior. Either it can move antero-superior or it can go posterior-inferior. So the pelvis moves in this pattern. So if the pelvis is located more anterior to that, what you can say, sacral sulcus has a larger width, so it could be antero-superior dysfunction, or if the sacral sulcus is not palpable, it could be your posterior-inferior dysfunction as well. So I'll just show you one video, small video, in which you can know how we can do pelvic mobilization.
Alright, today we'll be talking about the pelvic mobilization. In the cases where the pelvis goes into a dysfunction of posterior-superior misalignment, so we have to fix it again back into antero-inferior situation. So the glide which we give for that, we'll be discussing it today here. So you have to keep your patient in prone position, you have to keep the knee flexed to 90 degrees. Along with that, you just have to keep your legs into the hip joint into extension, and along with that little abduction and internal rotation like this. Now you'll be just keeping the heel of your hand onto the superior iliac crest, posterior aspect of the superior iliac crest, and you'll be pushing it like this into the direction anterior and superior. It will not just be anterior, it will be anterior and superior. Okay, so the direction of the glide would be this, not this.
All right. So I'll not be taking this inhibited root concept because that will take a very long time. So I'll just rest my voice here, just say a few words like, it's always unlikely that one intervention will work for everybody. So always prepare to be flexible. Okay. And a great rehab is always to be flexible and be ready for every time. So this is my book. It's available on Amazon. You can, if interested, you can get a copy of it. All right. I would like to thank my physio for making it possible to start it well. One last word from me, and then I'll be gone. Okay. Doctors don't make you healthy. Teachers don't make you learn. And trainers don't make you better. So you must always remember that at some point of time in your life, your growth is your responsibility. Thanks a lot. Thank you so much. If you have any problems, you can contact me here at any time. All the social medias, I'll always be there. I respond there. For any questions, I'll be able to. Thanks a lot.
Thank you so much, sir, for your informative sessions.
Just a second.
We have our next speaker, Dr. G. Balaji sir, the principal of Nargund College of Physiotherapy, Bangalore. Welcome, sir. Over to you.
Happy World Physiotherapy Day. As on September 8th, we are all celebrating World Physiotherapy Day. So I extend my wishes all physiotherapy professional fraternity. Today my topic is the clinical differentiation between fibromyalgia and myofascial pain syndrome. So what is fibromyalgia? The fibromyalgia syndrome and the myofascial pain syndrome both almost look similar, but there is some differentiation is there. So this is like a group of chronic non-inflammatory pain syndromes. This affects the muscles and the tendon insertion also. There are some criteria of diagnosis both the diseases in the presence of the tender points and the trigger points. So both are different, but clinically, sometimes this terminologies will be misusing that tender points and trigger points. So according to the ACR criteria of fibromyalgia FMS is characterized by the presence of the tender points. But where is the trigger points? This typically found in myofascial pain syndrome. So there is a literature support the fibromyalgia and myofascial pain syndrome. This starts from almost 1985 onwards. It is there. So there is a criteria of the differential diagnosis or the presence of the tender points in FMS, fibromyalgia syndrome, and this non-specific and soft tissue pain and the presence of the regional and characteristic referred pain. The muscular trigger points, it's like a taut band. So there is when we palpate that, there's a taut bands will be palpated on the skeletal muscle. So that is there in the myofascial pain syndrome. So what is the difference between tender and the trigger points? So the etiology of the tender points, it is not still unclear that. And there is a certain which specific soft tissues are under the fibromyalgia patients. So there is a myofascial trigger points that's found within the taut bands of the skeletal muscles. That's called as the nodules. Okay, when we palpate, we can palpate the kind of the nodules. We can feel the nodules or the taut bands also. So that's called as the nodules textures, the palpation. So that is a trigger points. So when you apply the pressure in that particular the spot, the patient will shout. So it's a triggering the pain. That's what the trigger points. Tender means it's a generalized. All the points everywhere will apply the pain pressure. The patient will here pain. All the places the patient will comment there is a pain. So it's a tender. So it's a tender points. So what are the signs and symptoms of myofascial trigger points? So there is a palpable nodules. It is often located close to the muscle belly. Where is the muscle belly fibers? The muscle belly is there. So in that area will be there. Mostly it will be often single. Sometimes one trigger point will notice it may be located just nearby, but that may not be that much triggering the pain. And there is allodynia and hyperalgesia of the myofascial trigger points. And the trigger points, when there is a referral to the myofascial trigger point, one particular spot, if you apply pressure, so there may be the referral that it will be extending that place also, and around the place also the pain the patient will get, but it's originating from that triggering the spot. So there is a normal pain sensitivity outside the myofascial trigger points also, and there is a local twitch response. Sometimes when you apply the pressure, you can feel there is a twitch response and followed by the local contraction also. Commonly when there is a dry needle, if they put on the trigger points, so there is a twitch, easily will be visible that. So there is a twitch response when you apply the pressure or the things, so easily twitch response and the contractions. So local contracture in the biopsy materials. Okay, and there is a peripheral mechanisms. There is a probable peripheral mechanisms also in this myofascial trigger point. So what are the signs and symptoms of tender points? There is no palpable nodules. Location will be often very close to the muscle attachment, where the muscle attached to the bone, and that attachment site only that pain will be there. And there is a multiple by definition. Everywhere when you apply pressure, the patient will say, yeah, everywhere I'm getting the pain. Okay, and there is allodynia and hyperalgesia will be outside that tender points, not on that area, outside that. And there is a pain under the psychic stress. The patient will be the stressful in nature. Definitely that anxiety and the stress that will aggravate the pain. And this is unspecific histological changes in the biopsy. In the biopsy also is there nothing, you can't find out anything. And central nervous mechanism. This trigger with the and this will the condition will be aggravated by the central nervous system. There is electrodiagnostic evidence source also. The differentiation, tender points and triggers, mostly the several the past studies also. It has been evaluated this electromyographic activity of myofascial trigger points. So there are kind of evidences shown that, and there was no points and trigger points are associated muscle bands. So there is no electrodiagnostic evidence on ongoing that denervations or the focal muscle spasm that is also found associated with the myofascial pain syndrome or the fibromyalgia. So these are all the kind of evidences, the references is also given. So there is central sensitization. The central sensitization it plays an important role here in both the fibromyalgia and myofascial pain syndrome. So central sensitization phenomena in fibromyalgia, this will be explained the patients with the fibromyalgia, given the pressure and the healthy individual. So it is unique in the fibromyalgia. This occurs in the painful conditions like irritable bowel syndrome, overactive bladder, TMJ syndrome, idiopathic low back pain, multiple chemical sensitivity. Okay, so these all the things will be have associated in that. The symptoms are currently believed to be the result of disturbed brain functions, and there is abnormal pain processing and autonomic nervous systems also, and ANS dysfunction in fibromyalgia. So in the fibromyalgia, the patient will have in the stress condition, and even the autonomic dysfunction also will be there. So which will be triggered by the central sensitization. So central sensitization in fibromyalgia, this will be understood easily by the direct imaging of the brain. The rest, or there is a shortly after the application of the painful stimuli. So both in the rest position, and once the pain stimuli is given, again there is a brain imaging has been taken. So this brain imaging is a 99 MTC ECD brain perfusion. So this is what will be taken that. This reported that the fibromyalgia patients had increased activity in some areas of the brain. There are certain areas of the brain, there is activities will be increased. So which area of the brain is activity has been increased, and that corresponding the place of the peripheral area. For example, like a sensory cortex. Sensory cortex. If there is the shoulder area of sensory cortex has been overactivity, hyperactivity it is there. So patient may get the pain on that shoulder and the musculature, in and around the shoulder and neck musculature. So in the frontal, cingulate, and even there is a medial temporal, and there is a cerebellar cortex. So this will be exposed after the pain stimuli. Also again they have taken this scanning. The scan are shown. This scan are shown that below orange, yellows areas, and this all have increased activity. This compared to the healthy individuals, and there is a blue areas. This represent decreased brain activity. So this is what the activity of the brain. I'm enlarging and showing that. Yeah, this blue colors where it has been shows. So this is a decreased brain activity. This is yellow color, increased activity of the brain. Some areas so there is a orange color. So this orange color and the yellow, the color this represent there is increased brain activity. So this area of orange or yellow colors corresponding the part, extremities or in the spine, or if it is there on the hamstring area or the leg, okay, the patient will get the pain. And this central sensitization, when the patient get anxiety or the stress, definitely the pain also will be aggravated. So this is what the brain activity. So this activity of the brain, this correspond with this myofascial pain syndrome. So this is what magnetic resonance elastography, next one. So there is a magnetic resonance elastography. These are used to assess the taut bands of the skeletal muscle. So there is an experiment also has been done. This performed a 1.5T magnet resonance imaging scanner. So this shear wave propagations was imaged, and there is a shear stiffness was it's a reconstructed using the matching, and there is a magnetic resonance elastography. This may have a potential for objectively. There is a characterized myofascial taut band, so we can also easily catch the myofascial taut bands. And once the taut bands has been detected, and that can be palpable, and mostly that what is the size of the taut band and how thick it is there, this can be detectable by the clinician's finger. So what is the fibromyalgia and the myofascial pain syndrome? So commonly this women suffer with the fibromyalgia than men, because women's anxiety role is more than the men. But the ratio of men and women is equal in the myofascial pain syndrome. So in the myofascial pain syndrome, can see the taut bands. Okay, so the mechanism is on the peripheral. And fibromyalgia, the mechanism is it is not there here. It is in the center. So in the fibromyalgia, the muscle have generalized hypersensitivity, while in the myofascial pain syndrome, the muscle have the muscle area located away from the trigger points. So usually that will be the normal sensitivity. In and around that area will be normal sensitivity. So with the fibromyalgia, there is a total body ache. Everywhere the patient will get a pain. So all the places, the patient will say here, here, all the extremity. Even if you touch the neck, then the patient will say here also is the deltoid region, biceps, all the places. So throughout the body, the patient will get a pain. Reason, there is no peripheral cause. This is central mechanisms. Because of the central sensitivity only, that patient will have pain. And patient will ask physio to keep everywhere that IFA also. So that is also not possible that. And we are trying to understand what is that. Why the patient is complaining everywhere there is a pain. So the myofascial pain, so there are the specific pain in specific areas. So that's for myofascial pain syndrome. The particular that one area, there is a patient complaint where we palpate, you can feel the taut band. Once you apply the pressure, patient will shout. So that's which reproduce the pain. So the patient sometimes will feel the jerky pain. So other than that spot, the taut bands, when other places if we apply the pressure, no pain. And with the myofascial pain, the area is not affected by the trigger points and don't hurt. But the fibromyalgia, the area outside the trigger points is still an ache. So this is a differentiation. And fibromyalgia is it's a neuroendocrine disorder, and myofascial pain syndrome is a neuromuscular condition. So the patient who come with a whole body pain, and definitely there is a fibromyalgia. It's not a myofascial pain syndrome. But the terminologies are often it is misused. So fibromyalgia like that. So the patient who have fibromyalgia, so on the locally, on the peripheral area, whatever we apply in this, even when you apply IFT, ultrasound, any other mobilization, soft tissue mobilization, will never that much work on that. But the patient who have myofascial pain syndrome, yes, there is a taut band, yes, we can apply all the things. But other differentiation, there is a sleep disturbances usually occur in both the conditions, both because of the pain. But in fibromyalgia patients, as the patient is already in the depressions or the anxiety, so definitely the sleep disturbances also will be there, and the pain also will not allow the patient to sleep properly. So in both the cases, there is a fatigue will be common, and due to lack of the less sleep, and there is a fibromyalgia, there is due to the neuroendocrine imbalance, and myofascial is due to the pain. So because of neuroendocrine imbalance only, the patient will have sleep disorders in fibromyalgia. But in myofascial pain syndrome, it's because of the pain. So there's a taut band. So once a band shrink, okay, constrict, the nodules also will increase. So patient will get a pain. So muscle function will be reduced. So patient will get a pain. So there's a cognitive defect that also will be there in fibromyalgia. And also in present myofascial pain syndrome also. But commonly this kind of cognitive impairments, the deficits, so that will be more in this fibromyalgia. Even there is a proprioceptive dysfunction and autonomic dysfunction also will be present in the fibromyalgia. So there is a deep aching and there is a burning pain in the fibromyalgia will be there, and is different than the pain of the multiple trigger points. So if there is a trigger points, if it is at that spot only will have a pain. But other than remaining everywhere, the patient will get a pain. But commonly, this kind of fibromyalgia patient will complain that I have a burning pain. Okay, my full upper extremity is burning, my lower limb is burning. So all the part of the muscles, full lower limb, I'm get a pain. So these all the things are complaints of the fibromyalgia. So it is possible to reduce trigger point pain by the many of the conservative therapy. There are many conservative treatments on even soft tissue mobilization, stretching of the muscles, even kind of ischemic compressions, dry needle therapy. There are so many other all conservative therapies available to reduce the trigger points. But there is a pain with the fibromyalgia, severe fibromyalgia. So the problem is not in the local. The problem is not on the muscle. Problem is not on the skeleton. The problem is on the central. So patient may not want to touch the single sheet. Okay. So even if you touch one place also, no, the patient will not be satisfied. So here also I have pain. So patient will keep on tell all the places. Everywhere if you apply the pressure, again the patient will complain another new point. So the as it is not a trigger point, okay, as the therapist is not feeling the trigger point, if the whole limb, if it has been paining, so definitely it is not a trigger point. So this is what finally what I am going to discuss here is the central sensitization is a important phenomenon of the tender points patients have the fibromyalgia. So fibromyalgia is a systemic disease process. Commonly this affects the dysfunction of the limbic system and the neuroendocrine problems. The patient have a neuroendocrine dysfunction also, and the autonomic dysfunction also will be present. And there is a patient need a treatment approach like psychotherapy will be required. Even the patient need a counseling, psychological treatment also will be required because the problem is on the center. So there's a low dose antidepressant medication also will be prescribed for this kind of patients, the patients who have the fibromyalgia. And even the exercise program will be that mild to moderate exercises program will be given. And myofascial pain syndrome, the condition arises from the referred pain, and there is a muscle dysfunction. This problem is in the peripheral, there is not in the central. So there is a dysfunction of the muscle only. This is caused by the trigger points. So once it's been released, the trigger points are the things. Once you give a stretch the muscle, when you regain the muscle function back, so patient will come back from the pain. So there is a manual treatment method, ischemic compressions, various other all treatment methods, stretching techniques is available. Ischemic compression, dry needling therapy, all the things will be available. Even chiropractic practices, so that also has been available. So these all the treatments, conservative therapy will definitely reduce the myofascial pain syndrome and reduce the trigger points also. So these are my references of trigger point and tender point differentiation. My idea of the presentation is mainly as a physio, we are supposed to differentiate the tender points and the trigger points. First, number one, the patient who is complaining the whole body, the pain, many times will be goes with the particular every area, all the place of the thing will be considered for the treatment. So which will not be required. We have to direct the patient to go for the psychotherapy and psychological psycho counseling also. Okay, so thank you very much.
Thank you very much, sir. It's really a very interesting and informative session by you in a short period of time. Thank you so much, sir.
Thank you, sir.
Next, our speaker is Dr. Parijat Kumar sir. He's going to take the session on manual therapy in India and abroad. Over to you, sir.
Okay, thank you, Dr. Pradyot. Thank you, everybody, for giving me this opportunity. Thank you, sir. That was a good explanation on fibromyalgia, and Dr. Himanshu was also quite good on explaining the different parts of manual therapy. So let me introduce you myself. Can I share the screen over here, I guess?
Yes, sir.
All right. So let me tell you a little bit about myself. I'm Dr. Parijat Kumar. I'm the Director of International Sports and Orthopedic Manual Therapy currently. I'm a physiotherapist. I've done my master's in exercise and sports sciences from Texas, USA. I've done my doctorate also from Arizona, USA. I've done my clinical exercise specialist thing from American College of Sports Medicine, and I'm also a certified spinal manipulative therapist from USA. So I worked and received my education in US for 5 6 years. I worked in US for 5 years, from 2010 till 2016. I was there, and I really learned what are the things and what are the differences. I mean, actually, no, I know better that what are the differences between the Indian setup and the Western medicine and the manual therapy. That's what I'm going to discuss over here. And this is a very general topic, guys. I'm not going to discuss too much into detail as Dr. Himanshu and other speakers did, and they were quite specific and into detail of their topics. I'm going to go very general as what is the evidence-based manual therapy in India versus abroad. Abroad, I will speak more about the US part, but I know about the European part, the African part, the other countries part, because under our organization where International Sports and Orthopedic Manual Therapy, we are also conducting all these labs and webinars where we have students and clinicians from all over the world, a lot of them, and I get to know about what their curriculum and practices are. So moving forward, if I'm sure there are students, I like to define the definition first. I won't take much of the time over here. So let me move forward. Sorry. All right, there you go. Let me see. I'm going to increase the. First of all, I see the definition of evidence-based. I mean, people still don't know whether, I mean, I'm not expecting much from the students, but I'm sure many of the students also know this, that first of all, we all speak that what is evidence-based. I mean, everybody says that I am practicing evidence-based. If I ask you what is evidence-based, believe many of you will not be knowing the definition of evidence-based. So if people know, they can mention the answers in the chat, that what exactly do you mean by evidence-based? And I come across, I give a lot of feedback and surveys to the students and clinicians, and many people say that yes, they think they are practicing evidence-based, and they're actually, sorry to say, that they are still following the old school of thought in the elementary education. So you need to know what exactly is the evidence-based first. So forget about all the doing masters, doing higher studies, doing etc., or studying abroad or here and there. You at your basic level, you need to know what does evidence-based mean. Evidence-based, as the name suggests, everything around you is all evidence-based. You are eating, you are using a toothbrush, you are using a toothpaste, you're using anything. Everything is actually evidence-based. There have been lab tests, there have been evidence that yes, this is a material or this is a tool that you can use for. That's why you need to have evidence of whatever you are practicing. So evidence-based, if people know their researchers, that they are the 5 levels of researchers. So you need to know, yes, exactly, the scientifically proven and research-based results. I'm just looking at the chat. So you also need to know what research-based and what is the quality and the level of evidence of that particular thing. Now, say, for example, I don't mean to offend any school of thought, but if you ask me that what are the evidences of cupping, level 1, there are 5 level of evidences: level 1, level 2, level 3, systematic reviews, randomized control trials, case expert, case opinion, cohort, and all that stuff. Can somebody please unmute the other person, please, because I don't know whether
Yes, I have, sir. I have.
Yeah, because somebody is telling that there's a lot of disturbance during the session. So can you mute, please, if you don't mind? So yeah, evidence-based is you need 5 level of evidences, and I don't see any test or treatment below level 3. If it is level 3 and above, if it is level 1, if it is level 2, or if it is level 3, if it is a randomized control trial, if it is a systematic review, then I go for that test or a diagnosis or that treatment technique. I'm not going to see an expert opinion. Sometimes it works. I'm not going to see any case studies and all that stuff. Sometimes it works too. But I'm going to see the level 1, level 2, level 3 evidences where I can be a better evidence-based manual therapist. Dr. Himanshu and other speakers have been talking about the manual therapy, and that's what you need to understand first that you are a physiotherapist, a physical therapist. You are a therapist treating physically. So my humble request is try to be a good physical therapist and not depend much on the machines and the electrotherapy. They are required. I understand they have their own importance at their certain points, but try to be a better hand and a manual therapist. That's how you will get your patients respect and the society's respect. I'll share a small story. I get a lot of calls and messages from students and clinicians, and they tell me, they ask me, so do we need a council? Why is the salaries of PTs in India so low, and why are we paid so less? My humble answer to this is very simple. I mean, if you are not practicing evidence based, and if you're just practicing electrotherapy on your patients, I'm sorry, the patients might not see that hard work. I'll give you my example. If I'm working on a patient, I'm working mostly on the manual therapy part. So I'm working with my hands on my patient for at least 30, 40, or 60 minutes. My patients see that I'm working hard on my patient with my hands, evidence based. And then I get that respect, and then I get that consultation or the fees or the salary or whatsoever. But if the patient sees that you are just applying the machines and the modalities, hot packs, cold packs, which are necessary, as I understand, but if you're not practicing manual, the salaries, the revenues, they're not going to go high. All right. So evidence based, please understand the level of evidence. All right. Manual therapy. There are many aspects of manual therapy. I call physiotherapy as manual therapy too. I haven't used electrical modalities for the last 2-3 years. So I don't use electrotherapy at all. Hands and lifestyle and diet and exercises, motor learning is sufficient enough. Manual therapy includes all these lists that are there. If I miss anything, please pardon me for that. But you need to know that is what physiotherapy is: mobilizations, manipulations, soft tissue releases, muscle energy techniques, myofascial taping, dry needling, craniosacral therapy, and many more. Understand what is manual therapy. I'm going to discuss some differences in India as well as abroad, and you will understand how come manual therapy is different from here to there. So I won't be taking much of the time on this. All right. So area of differences, what I feel, I mean, I'm not going to compare over here between the Western and the Indian stuff much, because there's no point in kind of comparing things. We should actually understand first within our own country. So number one area of difference that I find is the education. I have come across different university curriculum. I am from Delhi University. I did my undergrad from Delhi University. So the curriculum of Delhi University is different. If I take a university from the South India, or from Rajasthan, or from Eastern Zone or Western Zone, I see their curriculum is different. So the number one area of difference which has to be regularized, uniform, and standardized is your education, the education curriculum. Sometimes it is kind of a funny for me to see that there are students who are studying anatomy and physiology in the second year, and many of us study anatomy and physiology in the first year. Yes, I'm right. So many of the students are also studying anatomy and physiology in the second year. I don't understand that. There should be a set regulation and standardization for the education part. Number two is the clinicals. I don't want to go too much into the councils and associations and all. Clinicals is quite, I mean, the problem is anybody is practicing anything, to be honest with you. I see PTs who are, working as a weight loss specialists. I see PTs who are working in skin beautification and in VLCCs as well. I see PTs who are working in Gold's Gym just for the sake of like a personal trainer or exercises. Try to differentiate yourself. You are a physiotherapist. You are not a personal trainer. You can do better than them. You are not a beautician. You can do better than them. You're a weight loss specialist. You're not a nutritionist. I see many PTs over here. I know that you need to earn your bread and butter, but they are doing these nutrition courses, these yoga. Many people are going to yoga certifications. Totally understand that, and it's very good to do that to increase your knowledge. But please understand, you are a physiotherapist before any other specialty. You cannot be a nutritionist tomorrow, or you cannot be a yoga specialist. You can kind of add, and please refer them to their respective specialist. The area of difference one is the revenue and the CEUs. Revenue, I'll elaborate quickly over here. Revenue, I see the marketing over here, people, I mean, these are the weaknesses and the limitations that I'm discussing, and then we can discuss about the strengths and how to tackle them. I see a lot of clinicians over here, they are actually busy marketing themselves, and including the students. What it means is, say, for example, I see some of the students doing a 1-day or a 2-day course, and then they are adding those names in front of them. Say, for example, you do a 2-day dry needling course, or you do a 2-day manual therapy course, and then I'm sorry to say they become a certified manual therapist and they become a certified dry needling specialist. That's not true. What you're trying to do is you're trying to market and put names in front of your, try to put suffix in front of your names. That will just market you and attract the patients. Believe patients, they are not going to know what suffixes you have in front of your name. The patient needs to be fixed, bottom line. And in today's world, where the awareness is increasing, the patient wants to be fixed quickly. We do a lot of manipulations here in international sports and orthopedic manual therapy. I'm not saying everybody to start with the manipulations, but manipulations, quick fixations of the patients. We see a lot of sports people, a lot of orthopedic people coming to our clinic and our organization. They want quick fix. You cannot be simply applying electrotherapy and doing exercises and depending upon the doctor's script and the medications for them to get better. Healing will take place, they will get better, but you need to expedite that process as a learned, literate physiotherapist. Talking about the CEUs, which is the continuing education units, which I find quite lacking over here in India, especially as compared to the abroad, to the different countries, because, and the problem is about the licensing and the regulation, because there is no such license over here. So you don't need to maintain your licenses, and that's why you don't do any CEUs. And that's why the many clinicians who are like quite experienced, many doctors who are quite experienced, they are still following the old school of thought. That's why I mentioned evidence-based in the beginning. You just need to not follow the evidence-based, but also the latest evidence. You cannot be following the 1980s or 1990s researchers of doing manual therapy of old school of Mulligan and old school of Syriacs or Maitland. They do work, but there are latest evidences which can fix your patient quickly. All right. So try to engage yourself more in learning and in continuing education rather than just marketing yourself. I'm here just to guide you if I need to offend anybody, but if your marketing is important as well, for that I would request you to learn before you start marketing, because your patient needs to be fixed. All right. When I say evidence-based practicing CPGs over here, I mean, few of them good learned experienced clinicians do practice, but when people say that, yes, I'm practicing evidence-based, and if I ask them that, okay, you are using an assessment tool or a treatment tool, what is the rationale or what is the reason for this? All right, just give me a second. Sorry. I guess the internet is working. Yes. Can you
Yes,
hear
sir.
me? Can you hear me? Hello?
Yes, sir. Yes, sir. We're audible.
Okay. Sorry. All right. Yeah, where were I? All right, sorry. Yes, I'm going to quickly. Okay. So clinical practice guidelines, guys. Say, for example, I'll give you an example over here. We use a lot of manipulations. We do a lot of manipulations, I told you. But it's not like I'm not going to impress any patient and the patient is going to come to me, okay, come and I'm going to manipulate you. And yeah, you hear those popping sounds and you are impressed and blah, blah. And I charge them like 2,000 or 1,000 rupees. No. If I know that my patient has numbness or tingling in the leg, if I know that my patient has hip internal rotation less than 35 degrees, if I know that there are fear avoidance belief questionnaire scores are less, then I'm not going to manipulate them. You need to know all these criteria. These are called clinical practice guidelines or clinical practice criterias, that where to use this assessment technology assessment test, where to use these treatment techniques. Those are called clinical practice guidelines, and these are all evidence based upon the latest researches and the scientific proofs, as many of the people said over there in the chat. So try to know these CPG guidelines and then start practicing evidence based manual therapy. All right. Limitations that I see, and it's everywhere. It's not only in India, but in abroad also in other countries. I see a lot of people not practicing really evidence based, and their limitation are in their assessment, the diagnosis, the kind of a diagnosis they are doing, clinical reasoning. Patient, I'll give you example over here. Differential diagnosis: patient coming to you with a neck pain or the upper shoulder pain. The most common thing, a student, if I'm asking a student about the assessment, what they do is, okay, they start palpating it. Yes, the upper traps and the elevators are quite tender. And then you start putting the hot packs and the ultrasound and massaging and dry needling and blah, blah, etc., etc. What if the patient's blood pressure is high? What if the patient are having gastrointestinal upset? You know that you might say, we know that. I mean, patients can have, but did you ask those questions to your patient? I see a lot of patients, because of this stressful life these days and the white collar jobs and corporate jobs, they are having a lot of stress. They can have anxiety issues, they can have blood pressure issues, they can have gastrointestinal issues. So if you don't ask those questions to your patient and you start putting electrical modalities and just kind of massaging the areas and manipulating it, and believe me, you can help the patient symptomatically, but the root cause would be still there. So that's what we are trying to teach, and that's why these webinars and these Dr. Pradyot Master Academy and we at International Sports and Orthopedic, we are trying to teach that please try to assess and treat the root cause of the problem rather than just the symptoms and the pain. The pain is very subjective. I'm not in a good mood. I can have my pain increased, as Dr. Himanshu mentioned about the sins, the severity and the irritability. So the severity and the irritability can increase if I'm not in a good mood. But if I'm in a good mood, I'm traveling abroad, I don't feel my pain. So psychological, a lot of component. Clinical reasoning and differential diagnosis, that's what you need to do and identify those as a limitation. Again and again, I'm focusing on the evidence-based management. Evidence-based management, first you need to diagnose, assess, clinically interpret that, and then start managing. All right. Another reason for why people think that the salaries are too low, and why the profession is, what is the comparison, is one of the payments that in the other parts of the countries like US and Europe, most of the insurances are paying for their physical therapy or physiotherapy. But in a country like India, 80 or 90% of the people are actually paying out of the pocket. So, and actually, believe me, guys, out of the pocket is good, because the insurance reimbursement, when I was practicing in US, the insurance reimbursements are quite low. So say, for example, I can quote you like an insurance reimbursement over here in India, like CGHS, which is a central government insurance. They pay you according to the modalities, and the amount that they pay you is like peanuts. And believe me, you don't want to hear that. So don't rely on these insurances, because in the other countries as well, the market is turning out slowly and slowly into out of pocket things. So people are trying to pay out of the pocket, and that is what is working for the physios over there as well. What is the effect? What are the factors that affect these payments? Obviously, the market influence. What is the market influence? I see, I'm sorry to say, which is market influence and service provided are like the same thing. I see a lot of physios have started adding, names after their name. Suffix like certified osteopath, certified chiropractors. We have a video on our iSOMT YouTube channel where I humbly say that, guys, that's not right. You are a physiotherapist. You cannot be a certified chiropractor. You cannot be a certified osteopath. You cannot be a certified manual therapist in 2 days, 5 days, or 10 days. These are like motor learning programs. It is something like I train my friend and he can be a certified physiotherapist in 2 days. Doesn't sound right. And it's not right. So these are different professions. Respect those professions. It's involved in a lot of hours, clinical training. You can learn the concept. You can do the manipulations. As I said in the beginning, I gave my introduction as certified spinal manipulative therapist. I do a lot of manipulations, but I don't call myself as a chiropractor. All right. So you can manipulate over there and you can market. I understand we need to earn our bread and butter, and many patients sometimes ask for these professions that I want a chiropractic session. I tell them honestly that I'm not a chiropractor. I'm a certified spinal manipulative therapist which can perform manipulation. As simple as that. Okay. So please stop writing these suffix in front of your name. As I said, before you market yourself, learn the core values and the strength of those things. Learn how to manipulate, learn those clinical practice guidelines, learn the evidence-based assessment and diagnosis first, and then start using it on your patients. So the service you provide gives you a lot of payment. Like as I said, if you're just putting electrical modalities, your patients say, okay, I might give this person 200, 500, 1000. But if you're asking for like 2000 or 3000 rupees for just applying electrical modalities, believe me, the patient is not going to come for more than 2 times. But if the patient sees you working hard manually, evidence-based, the patient will come to you. So that's why I said you need to work hard manually, and that too evidence-based. You need to create a patient-friendly environment. As I mentioned over there, you need to be humble. You need to be polite. Those all characteristic of a physiotherapist will come into the picture so that it helps you build up the revenue and your salaries. Salaries and revenues also affect the payment. That's why you start practicing evidence-based manual therapy. As I said at the end option, believe me, your payments, your salary, your revenue, everything is going to go high. Now, students ask me, what is a good school? What is a good school of thought to practice? Dr. Himanshu also said in his lecture that you cannot blindly follow one school of thought. You cannot blindly follow Syriacs. You cannot blindly follow Maitland. You cannot blindly follow Mulligan. You cannot blindly follow one school of thought. You have to be flexible. You have to check your patient's symptoms and signs and then go for it. Clinically do the reasoning. This comes with experience. Do evidence-based, highly sensitive and specific tests on your patients, and then come to a conclusion and then start treating. This takes time. This is a procedure. This is a process, and that's how you learn the assessment and the diagnosis. All right. Almost coming to the end. Evidence-based manual therapy, a combination of the clinical practice guidelines, manual therapy, and experience. How you do it? Please keep on honing your skills and keep studying, continuing education units. In India, we don't have licensing. I understand that you don't need a set requirements, but for yourself, invest in your education, invest in these programs, invest in an evidence-based program. My humble request is if somebody is making you a manual therapist in 2 days or 5 days or 10 days, he's just making money. I'm sorry to say that. He's just making money. You cannot be a manual therapist in 2 days. You cannot be a dry needling specialist in 2 days. You cannot be a taping specialist in 2 days. You need to study the evidence first. Believe me, we Indians are specialists in actually researching a lot before we spend a single penny. So I don't know why people are not researching the evidence when they sign up for a course like that. Are you really studying the evidence of any XYZ course and signing for it, or you just want to add suffix after your names? Please don't do that. Try to learn whatever things it is, and if it is not evidence-based as well, you can learn, but try to differentiate. Try to use them efficiently on your patients, because you need to fix your patient. You don't need to fix the symptoms, you need to fix the root cause of the patient. As I said, there are courses, webinars, labs like these we keep on doing. Dr. Pradyot has been doing, we have been doing at International Sports and Orthopedic Manual Therapy. Manual therapy programs are there. Again, I'm saying do a proper evidence-based, ethical, and economical. believe me, I have started seeing this pattern that the universities are adding a lot of osteopathic and chiropractic curriculum in the university or the college just to attract students. And when I hear their tuition fees, the tuition fees are quite high. I mean, there can be more than 1 or 2 lakhs a year. There are some universities in India that I know that are adding osteopathic modules in their program. But they need to understand we are not osteopaths, we are not chiropractors. We can learn their school of thought, and that has to be evidence based, ethical, and economical as well. All right, guys, I understand that was like a very general talk. There are other speakers who will be waiting for their respective topics. And if you have any questions and concerns, please let us know at isorehab@gmail.com. We have an organization called International Sports and Orthopedic Manual Therapy. I thank Dr. Pradyot and all the students and the clinicians over here for listening to me patiently. I apologize if something that you don't agree with me. That's totally fine. That can be your perspective. But my only request is that earn your respect from the patients, from the society, and from the fellow clinicians. Don't just work on the symptoms, work on the root cause of those symptoms. Once again, happy Physiotherapy Day to all, and I hope everybody practices and learns a evidence-based thing. All right, take care, enjoy. Thank you.
Thank you, sir, for your informative session and valuable guidance for us. We have our next speaker, Professor Dr. Arunachalam Sir, Professor and Principal, College of Physiotherapy, Madhav University, Rajasthan. Welcome, sir. Over to you.
Yeah, very good evening. Just give me a yeah, I hope it is visible, right?
Yes, sir. Yes, sir.
Yeah. So thank you, Dr. Pradyot. Thank you, Mastro Academy, Physio Mastro Academy. Um, I think this is my maiden presentation here in this academy. There are lots of academies now for physiotherapy. I'm so happy for that. Um, these are all initial and very small steps we take towards a better education. Now our students are not dependent only on their colleges and the other conventional resources for getting educated. We do get a lot of academies like this. At least for the reputation of this academy, a very good education is being offered to people. So they have a lot of choice as well as now compared to before now. So in that way, I'm so happy, and I wish all of you a very, very happy Physiotherapy Day, because this is a very unique day. In all my somewhere around 20 years of my journey with Physiotherapy Day, I have never seen such an active Physiotherapy Day. So 2020, with the courtesy of COVID-19, we have come closer to each other, and we have celebrated a really valuable day and trying to know many things. Fine. Yeah. So congratulations to my previous speaker. He, though, was little harsh on people's practice, but that was true. That was needed. And so I could help with my presentation for people to know the evidences very faster and crispier. So that's why I included this topic. And another important reason for this is last time when I presented a similar topic in International Clinical Research Association, ICRA, there was a very good response for this presentation. Many people said that they were not aware of certain things. Okay, so nothing much, but the basic things what you have to do in a PubMed interface. You need to know what is PubMed first of all. People confuse PubMed with Medline. So PubMed is the largest biomedical bibliographic information source on internet. And it's a search engine. It's a simple search engine which incorporates Medline database. Medline is the database where all your medical, biomedical, paramedical articles, research articles are compiled and kept. And to browse through this Medline, you need something called as a PubMed. Okay, how you require a Google search engine to find the resources on internet. So PubMed is a mere interface, and you need to know how to browse through that. Okay, so the PubMed is being maintained by United States National Library of Medicine, which is commonly called NLM, and the National Institute of Health, NIH. Both are based on US. PubMed was started in 1996 initially. Before that, for any articles retrieval, you have to go to the libraries to get them. If institution has subscribed for any journals, the professionals were accessible only to those journals. But after the PubMed's advent, anybody is accessible to any articles. So it has the research, and the research works done by individuals have become more universal because of PubMed. Why should I know how to search PubMed? That is very important, because we spend a lot of time on internet and in the PubMed interface searching for our topic with faulty methods. So if we are going for a certain work, we need proper gadgets, and we should have the idea of how to use these gadgets. Here in this scenario, you have a work, you have a gadget, but you don't know how to use the gadget means, then you are going to beat around the bush for a long time. So simply to say, if you want to know, if you learn how to use PubMed properly, the time you can save is immense, and the results what you are going to retrieve by means of this systematic search is going to be much more compared to a vague search what you are normally doing. If you're already doing a systematic search, well and good, that is appreciated. Just listen to my presentation if you have any take home message. Otherwise, you can also contribute to this, my dear friends. So what I would like you to tell is, once you come to know about how to use this PubMed, please teach to others, because this will be of very useful information to many people. Teach to your students or teach to your friends. And whenever you are having a casual discussion, also discuss about this. Okay. Yeah. An analysis was done in 2015 on PubMed users based upon their expertise, that is in experienced and non-experienced PubMed users. The results of the study came out in strong recommendation of the experienced PubMed users retrieved relevant documents more quicker than the non-experienced PubMed users. Just one research which has been done on this thing. So the time taken and the number of informations you can get by means of this experienced PubMed users are high. So you should know how to use this tool. So I'm coming from the research problem. Um, the research problem is the source for research. Actually, you need to have a problem based upon which you can build research. So this research problem can be individualized. You may as an individual, you can have a research problem, or it may be an institution based. Maybe if you are joining a university, the university may be having some sort of a research problem and they'll be working on it, and you will be joining with that. Or it may be a program based. For example, if there is a program like a malaria eradication program or COVID eradication program, so they'll be having some sort of research problems, and you may join there as a research associate. Or it may be an researcher based. An individual researcher will be there. For example, if I'm there, if I'm doing a research on certain things, if I want some junior researchers, I can call upon junior researchers, and they all will be working on my research problem. So the research problem can be of any type, but once the research problem is clearly known, it may be from academics, it may be from clinical side, it may be coming up after you read a theory or a book or something like that. From wherever you may have a research problem, you have to put this research problem into a research question. So that is very important. So the research, I think in this COVID time, many people have spoken about this, and I think you all will have a very good idea, but still just I'll brush up this. So you have to put it in PICO model. So the PICO model is, P stands for the patient. What is the patient you are dealing with? I is for the intervention, what you are going to test. And C is for the comparison group, that is with which you are going to test. And O is the outcome, what outcome you actually expect as a result of this intervention. Fine, you have to split your question into these three into these 4 keywords, because these keywords are going to give you the search strategy. Based upon these keywords only, you're going to search. Fine. So we will see an example later. Okay. So there are some terminologies called as Boolean search terminologies. So these Boolean search terminologies are using if you want to know about physiotherapy modalities or physiotherapy interventions for pain relief. So if you should not write it as physiotherapy for pain relief. You have to cut short your words as far as possible using the keywords, and you can use this and in capital letters as a conjunction. So and should be in capital letters. That means you want to search both about physiotherapy and about pain. Any article pertaining to both of this will be surfacing. You won't have any articles which are only pertaining to physiotherapy. You will have articles only pertaining to physiotherapy and pain. You can also use this word called as or, where you are searching like you want to know how to reduce low back pain. You can say exercise or physiotherapy modalities. In that sense, or should be capital letter. Exercise or physiotherapy, and you can add and low back pain. So then that means exercise pertaining to low back pain or physiotherapy, any other modalities pertaining to low back pain will surface. So if you don't want certain things, if you're searching exercise for low back pain, you're getting a lot of yoga related articles. So you don't want that, because you want to purely go into scientific terminologies, and you don't want to assumption based interventions. Then you can write this word not in capital letters. So you will not get anything about yoga. If you want to avoid modalities, you can say physiotherapy, not modalities, pain management. So that is how it should go. So these search terminologies called as Boolean search terminologies. When you are using manual search, we can use it, but the new PubMed interface states that they are already incorporating these Boolean terminologies. So you need not use these Boolean search terminologies separately. We are giving you an option. That is how they're saying. So next is, there is something called as an advanced search operation. I'll show you practically also. So you can retrieve articles which are based on a certain topic, or you can retrieve articles based upon a particular journal or a particular author's presentation, or you can retrieve articles related to date of publication. From this date to this date, I want articles which are published on this particular field. And you can use some fields. So those things I will let you know. So you can also add a history. What are the search history you have added, which I really love that option, because I might have searched certain things 2-3 weeks before, and I might have got some results, but I would have missed certain articles. But if I go to my history, I can search out what are the search terminology I have used, and what are the search results available. So, and you should know how the PubMed works first of all when you are searching. So we say search engine optimization for Google, Google search. So for PubMed, you have something called as mesh terminologies. So this mesh terminologies are very, very important for you to know. So they are medical heading terminologies. That the mesh is expanded as medical subject heading terminology. For example, if you take low back pain, you may use this word, a keyword as low back pain in your management. How this low back pain has been reported by other researchers. Some people might have reported it as low back ache. Some people might have reported it as lumbago. You can see how many synonymous terminologies are there for low back ache. You may use a back space ache or backache continuously. All these things matters when you're searching. When you're searching back ache, it will give only back space ache results. It will not give you results of backache. But when you're using these mesh terminologies, you will have all the results which are pertaining to this particular mesh terminology. You will have all the results, and you will get more data and more research surfacing. So once you use the mesh terminology, you will also be guided to this particular sort of classification where you can select any one of this, because you might be looking into physiology of pain, you may be looking into surgical options of pain, therapeutic options of pain, or something like that. So you can specifically click here and you can make your own search patterns. Okay. I'll without wasting much time, I'll go into the practical sessions. Um, my screen is viewable now. You're able to see my PubMed search engine.
Yes, sir. Yes.
Yeah, thank you. So if you see, this is the PubMed search engine. How we normally search is we go and type low back pain physiotherapy or physiotherapy for low back pain. So if you use a word terminology, and this is manual searching, you are searching manually. So here you can get these articles. Fine. This manual search. If you go into an advanced search option, okay, you have this advanced search option. Click onto this and go to this build. So this will build your search for you. So I will take one particular compare with Bobath in motor recovery, which is better? That is my question, research question. Okay, Bobath better in bringing about a better motor recovery among stroke patients. So here my PICO P is the population. What is the population I'm dealing with? It is the stroke population. The intervention I may have a hypothesis which states motor relearning program is better. So I will say I'm testing for MRP. So it will be MRP is my intervention. Next, what is the comparison group? Bobath. And what is the outcome I'm expecting? Motor recovery. Okay, so I have divided my terminologies in PICO order. So now I'm going to search motor relearning program. Okay, so can you see here and add? If I add here, one second, one second. So motor relearning program. So I have added, there is an and here. I'm going to search for Bobath. So when I add, this is okay. If I don't want to add and, I can use or, I can use not. So these three terminologies are available here. Can you see this? Yeah, so you have to use any one of this. Here we are using and now I go for the search. So now I get the first result is of motor relearning program versus Bobath. Okay, so all these researchers would be pertaining to motor relearning program and Bobath. If you search just like that, you may not able to get such results. So these results are so crisp, and you have this 8 results are here. Can you see this? This is the totally 8 studies have been done. And you can see it is done from 2000 to 2020. So this column I always look into to see the how many researches are done in this time period. I will tell you one more thing. Okay, if you want to search like functional training, and stroke. Okay, so why this is important here, I will tell you. See, now the functional training and stroke has not got much of significance in the initial period, like even up to 1999 or 2000, it has not got you see from 2012 to 2021 there is a good amount of studies which are done on this functional training in stroke. You can see the amount of studies which are done slowly increasing from nil to maximum. Okay, so you can see the trend here. And also for the search, you can filter your articles here. Now if I use 2011 to 2021, I will get only these articles. Always when you're reporting a study, you have to use at least 5-year-old references. Don't use beyond that unless otherwise the topic is very rarely dealt with. Okay, so you can use the last 5-year filter using this particular option. Okay, next option you got is you can see whether you want abstract or full text articles. Once you see the if you are searching for a systematic review, you need full text articles. Okay, if you don't get full text articles, then your search is going to be waste. So then you can click here for full text articles. This will surface only the articles which have full text here. You can go what type of research you want. You want to know about randomized control trials, reviews, systematic reviews, meta-analysis, all these things you can click here. I always search like for systematic review, meta-analysis and randomized control trial. If there is insufficient data in these three, I'll go for the other cohort studies and the systematic reviews. You want first last 1 year published or last 5 years or 10 years, you can click here. You can also reset your filters by means of clicking over here. Or if you want to add on to some filters, you can click here and you will get this option. You can have your own add-ons. I normally use English language. If you click here, I want articles which are published only in English, because you may see many articles are published in some Greek and Latin also, which we may not comprehend. So English is default I use. If you want to have studies which are done only on male, you can click here. If you want to have articles done on a human being, mostly we search for human beings. Sometimes we search for non-human models when you are searching for motor control theories and certain biological studies. You can also go for non-animal studies. You can click the type. And if you click here, you get different types of articles. All these things. Practice guideline is a very important thing here. You when you are looking into practice guidelines for particular intervention, you will if you click this, you will get only the practice guidelines. Okay, you can go with specific type of journals. Medline is one type where we will get all our articles into. And if you want to search, for example, motor relearning, neurodevelopmental therapy for pediatric population, you will not get if you put more NDT and pediatric population. Instead of that, you can select this age category. If you want to know the results of NDT on pediatric population, you can select this age category and very well come out with the answers. So these are the informations which are available here. And I would like you to get introduced to mesh terminologies also. So I have searched many things. If I really want to directly go to the PubMed interface, you come down, just you have this PubMed interface. If you click onto this, you will directly go here, need not waste time. So if you scroll down, you will have this mesh database here. Click onto this mesh database. Okay, so if I type low back pain, okay, this is how it opens up. You have so many synonymous names to low back pain. Okay, so this is mesh terminology, and if you go to this particular part, you can see a search builder is there. So you want to know low back pain, epidemiology of low back pain. You can click epidemiology of low back pain, and you want to know about the etiology of low back pain, you can go for it. Okay, so you can, if you click here, you will build a search. Can you see this? You have built a search and you can search for this. The results will be very crisp. This is a very systematic way of searching. Okay, so that is terminology for you. If you have something like dystonia, which is a very common terminology used in medical field, where there are a lot of dystonias. You have muscular dystrophy related to dystonia, you have focal dystonia or writer's cramp, you have dystonia of the cervical spine, you have lot of types of dystonia. Cerebellar lesion, basal ganglia lesion also results in dystonia. So when you go to mesh terminology and search as dystonia, it will ask you what dystonia you are pertaining to. And you have lots and lots of dystonia types. So if you want to know more about the basal ganglia related dystonia, see here dystonia dopa responsive. So you can click onto this. Okay. Once you click onto this, you will be guided to the subsequent page here, mesh terminology. Okay. So here you can build your search and you can find out the results for this particular condition. Okay. So don't be taken by surprise if you get a page like this after you put your mesh terminology. Okay. For example, I always use this example in my presentations. If you are using, if you are searching like paleo diet, you want to know about the paleo. Okay, if I click paleo, okay, so sorry, I hardly get 95 articles on this. Paleo may be anything. If I give a paleo diet, so I'm not getting much about paleo directly on article is opening. That means there is only one result for paleo. So in searching, what do I mean by paleo? So I go to mesh terminology, search this word paleo, and even I don't know the spelling for that, so I just click paleo diet. It will give me what are all the things. See, it is actually called as Paleolithic diet. I have to search as Paleolithic diet. If I search using this proper terminology, you have so many synonymous for this: caveman's diet, hunter's diets, all these things. So now if I want to know about this Paleolithic diet, I have so many classifications here. Okay, so if I want to know the epidemiology and the history of Paleolithic diet, I'm creating a search builder and I'm searching now. Okay, see, I've got 23 articles. Initially I had only one article. Now I have 23 articles. So my dear friends, that's how you have to search. And finally, I would like to tell you, I really don't want to take much of the organizers' time. Such presentations, if they are more crispier, then they'll be nice. Otherwise, it will be too lengthy, means it will be boring. Here you have got login. See, I have created my login. So the best advantage of having a login is you will have a dashboard. If you have registered yourself, you will have a dashboard. See, whatever search I have done so far are saved here. My recent activities are saved here. Okay. If I'm searching low back pain, again, I'm just telling you for an example. So I like this article, this one particular two articles I like. I can save them here. Okay, I can save them. I can create a file and I can save them, and there will be a confirmation that citation downloaded. You have this downloaded here. Can you see this? It is downloaded for me. It will be in a different format. You can convert them into what to say, Word format. Okay, it is in set.txt text format, set text format. You have to convert it into Word document by going to Google, and you can click how many ever articles you want, and you can send it to you can save it for your bibliography. That will be very useful. Or you want to email it, you can email it. You want to send it to your clipboard, you can send it to your clipboard. Again, 4 items are added to my clipboard. Okay, so this is one advantage of creating a account. I can also add my publications into this. There is a column for that. An option is there for that. And it is also very important as a researcher. What is your research interest, where you are searching too much into it, and you have to get familiarized with certain topics, means you have to use a dashboard. Okay. You can see these are all the articles I have saved for my future readings. So you can do that. Okay, I think I have covered almost all the search. The new pyramid has become so easy for people in terms of searching. I think, yeah, this one option I forgot to tell you. Okay. Which I like, I want to save it for my references. I can directly go and click onto this and copy this. Once upon a time, how we do is we go and click onto this. Okay, and after this opens up, we will copy these topics separately, the author separately, the citation separately, and we will paste. And we have to modify to the our what to say referencing style. Here you can directly click onto this site and you can copy that and you can paste it in your bibliography. So that makes your work very easier. Okay. And one more tip for my students here, if you want to download not or I won't say this is what to say uh, sorry. So this is one website where you can get almost every article full text. So the website is sci-hub.tw. So what you have to do is, if you have an article, you have to paste the date of issue. For example, so I am looking into this hemiplegia, this particular article. Okay. This particular article is a subscription based article. I don't have a free full text here. It is paid. Okay. So this is there, the date of issue, DOI. I have to copy this DOI and I have to paste column. Paste it here. And if I go for the search, I'll get the full text article for almost all the articles which are subscription based. This is not a very legal way, but it's a sort of a hack. But I have used it many areas where, okay, sorry, this is a Japanese article, but it is full text is available here. I'll take this article. This article do not have a free, it's a subscription based. Yes, it's a subscription based. This DOI is here. I will copy this date of issue and I'll paste it here and I will get the full text article. If you see here, if the DOI is not available, you can also use this PubMed MID. This is an identification number. You can use this also in pasting here. See, you have got the full text article of this particular thing, which is a subscription based article, but you can get it. Okay. This is going to increase your understanding of the subject. So that's why, even though it is not legal, I'm just telling you. And with this, I come to the end of the presentation. Hope it is of some use to people. Thank you so much for the academy associated with this presentation and Dr. Pradyot, to whom I am very familiar with, for this opportunity. Any platform given to talk to fellow colleagues and students. I take it as an opportunity to talk to you people. Thank you so much. And if you have any doubts, you can come up with your doubts.
Thank you so much, sir, for this presentation. It was quite informative because most of the faculties they take classes on this theoretical type, but for researching it will be very helpful for all the students and the research practitioners. Thank you so much for your time, sir.
Thank you. Thank you.
Yes, sir. So, and also I would like to thank to our audience, to our participants who have been joined us since afternoon. I know today's schedule is a bit lengthy one. Still, I would like to thank you all for your patience. So, okay, sir, thank you. We will